Um, Dr. Braun, for those of you who join our grand rounds, is a regular attendee and uh, is very involved. And so thank you for that. And today it's our pleasure to introduce her. She's going to be talking to us today about something that we all thought was in the past, but who knows, might be coming back. And Dr. Braun is a board certified in internal medicine and pulmonology. She established the fiber optic bronchoscopy service at the Harlem Hospital and at Columbia Presbyterian Hospital. She was additionally the recipient of the NIH Pulmonary Academy Award, which allowed her to establish the medical ICU at Columbia Presbyterian Hospital, restructured the pulmonary curriculum in the College of Physicians and Surgeons Medical School, and developed medical residency and medical student electives in pulmonary disorders while conducting research on the mechanisms for sustaining um, eucapnia and COPD, other lung and neuromuscular disorders. She designed a talking trach tube, a flexible garnet for use for long-term mechanical ventilation using negative pressure pumps, and studied the reduction of respiratory muscle work during conscious mechanical ventilatory support in normal subjects and patients. She formulated a protocol for standardizing tracheostomy care for Columbia Presbyterian Hospital, and she was supported by research funds from the Stony Wood Herbert Foundation and the NIH. Um, so without any further ado, I will turn it over to Dr. Braun. Thank you so much.
Thank you so much, and happy spring, everyone. It's more of my slides than I'm gonna talk about, but I just want you to start thinking about this process, which I consider the miracle of ventilation. It is an incredible function that we have that we don't think about very much. I have a few disclosures. I'm an advisor to these companies making 21st century non-invasive ventilatory support systems. Anyway, I'm going to review a little bit of physiology of gas exchanges, old hat to you, so I'll skip through a lot of it, but I want to emphasize on CO2 homeostasis and its importance. A brief history of ventilators, very brief, and then we'll compare physiological differences between positive pressure, both non-invasive and invasive, with negative pressure ventilation, and then talk about what we can do for the 21st century with redevelopment of more modern negative pressure ventilators and the exsufflation belt. So here we go. It's a big, busy slide. I just want to remind us how important respiratory quotient is. We don't talk about it very much, but it really is very important to the relationship with CO2 production and oxygen consumption, because that's what the organism depends on. But incredibly, our system maintains a very narrow range of PCO2 between 35 and 45 mils of mercury, with lots of mechanisms to maintain that. We know that diet does alter the amount of CO2 produced. And so a mixed diet, you have an RQ of 0.8. High carbohydrate diet, especially when you're drinking alcohol, the RQ is 1, so you're making more CO2, but when you're under the influence of alcohol, you may not care. But increased fat intake will reduce the RQ to 0.7, which is much less CO2 produced. So why is it so important? Well, because optimal cellular life and function depends on pH and the narrow range of CO2. So what uses the most oxygen? We have a lot of organs, and they are variable oxygen consumption based on the amount of activity. And you see this in ICU patients all the time, and which organs become damaged more. Muscles are the most variable group of cells that utilize oxygen produce CO2. It depends on what they are doing. So at rest, it's more than skin, but less than the main organs of brain, liver, heart, etc. So yes, you get a little bit less when you get older, but the largest organ by mass and weight is the muscle, and the respiratory muscles are always active. Reduced muscle mass does occur with age, with sarcopenia, and chronic reduced activity, as in any chronic disorder in which there's loss of muscle, there is less demand on the system. As a consequence, the respiratory effort to maintain eucapnia is lower. It may be that's the reason why in patients with muscular disorders that their functional characteristics have to be a lot less before hypercapnia develops. Just remember that UCAP, good old eucapnia, is the constant with amount of CO2 produced by the alveolar ventilation. You retain that equilibrium, tightly controlled. Hypocapnia, does it have an effect? It absolutely does. So with hyperventilation, high altitude, severe disorders, it result in cerebral vasoconstriction and a host of symptoms. Hypotension itself has a direct effect on the CO2 cause vasodilatation, leading to hypotension. Alkalosis with the acute change, the pH alteration has a value that is 0.08 times 40 times CO2. And then with chronic, the constant is a little bit larger. So the major compensation you can see is in the change in bicarbonate as an attempt to maintain equilibrium and the pH for cellular function. Muscle cramps can be part of hypocapnia, so that many people may not recognize that. Hypercapnia has a lot more other physiological effects, which actually increases morbidity and mortality. And any reduction in CO2 excretion, the most common that we see is drug overdoses, but many lung and cardiac diseases cause it. But CO2 production increases in fever, which we see all the time, metabolic acidosis, in sepsis, thyrotoxicosis, and of course, alcohol. The renal inability to balance the CO2, bicarb CO2 system because it takes time. And the effects can be dramatic in many, many ways. You can see that in flushing and lethargy, inability to focus, headaches, dizziness, disorientation. Shortness of breath often may be a late complaint, but nausea and vomiting can be part of that. The higher the levels of CO2, the more depressed the brain is. And they've confusion, paranoia, depression, anxiety, twitchy muscles, palpitations, initially shallow breathing, seizures, and syncope. And it depends on the rate of rise and the degree and efficiency of other organs compensating for the changes. So it's a very busy slide, but it goes through, there's no system that is not affected by high PaCO2. So again, because of slow compensation, there's more impact. Well, we already know this, so I'm not going to go through this, but just to remind ourselves how widespread the symptoms of hypoventilation can be on the system. And that be kind of insidious for many patients. So how do we then decide what we're going to do? So we have to take a history, good old history. You have to do, and I favor ABGs because you can calculate a gradient from ABGs. It's very hard to calculate that from venous blood gases, though I know the venous blood gas is the favored. Then what do you do about it? Well, after you make the diagnosis, your choice of ventilations. Obviously, if it's very, very acute, there's no time for rapidity of change within the system. You have to intubate, but it's when to change it when you improved, or can you start with non-invasive ventilation sooner? That's one of the suggestions I'm making to this group. Because can you become stable with non-invasive systems? And what's the difference between positive pressure and non-invasive negative pressure? Well, patients and families have to buy in. The trials of choice we're going to go through, and then what's going to happen long term. So again, earlier recognition is always a benefit to patients because you can institute treatment sooner and you improve quality of life, you reduce hospitalization, they certainly reduce death. In the absence of elective intubation for intracranial pressure, trauma, things of that type, protecting the upper airway, all respiratory failure is respiratory muscle failure. Because anytime you put a patient on a ventilator, you've recognized the fact that the work of breathing exceeds the capacity for the patient to support the load. So that to me is a given. Well, we have a history here of using non-invasive systems. It goes way, way back. Man has been trying to support breathing since the BCs in terms of recorded record. And in fact, the first positive pressure described in the Bibles where God puts his mouth to man he created and blew and gave Adam life. Well, that was positive pressure. Anyway, there are other systems, and I'm not going to go through these in detail, but somebody was always trying to do something, and we're still trying to do something to help patients. So positive pressure systems, you already know that, acute problem. But there's risks of infection, barotrauma, a lost speech and loss of eating, and need for sedation, which I detest. And masking systems have many problems with skin injury, and any long term with compliance issues. And in children who are started on facial ventilation early, they actually mold the facial bones and the jaws and the teeth. Skin breakdown, aerophagia, and of course, patients hate it when they can't talk and they can't eat. And sedating them to get rid of that discomfort is not necessarily the best physiologic support system for the patient. Well, negative pressure systems in the past, beside the iron lung, the portal lung with the fiberglass model, I'll show you a little bit later, still available, but limited because the pumps have no longer be serviced since the Phillips bought up the country and then destroyed the available material. Poncho is copied by Demetalia. It's limited efficiency. The cost in the U.S. is prohibitive for DMEs. So the cuirasses that exist now that can be used are the Hayek bi-level. Fits poor with patient with scoliosis. It's very noisy, but it's good for kids because you don't need as much pressure difference. The Demetalia copied all of what we did in America because Jack Emerson patented nothing, so anybody could copy what he did for the benefit of people in other countries. The Exovent was a hospital model that was developed in England during the beginning of the COVID epidemic in order to prevent intubation for patients because intubation resulted in increased mortality. And the Venti was also developed for the same time during COVID for the same purpose. The difference is that the Venti is 3D customizable. Each person can have a laser fitting in order to get something that has less leak, is more comfortable. And trials are underway. All model systems need better pumps, which are being developed. The current available pumps are the Demetalia pump, the Life Care, and the Max Event, which is no longer serviced. Excuse me. Oh, I have a tickle. Anyway, this is how the distribution of negative pressure is distributed with different types of units. The whole body tank, you can see it's from the xiphoid to the upper thigh. So it has diaphragmatic and chest wall excursion, which is the largest change in tidal volume. In the wrap cuirass, especially the old-fashioned one, it was quite limited, but it does go from the xiphoid and to the pubis, symphysis pubis. And the new one, which is the Venti, is customizable so that it will match the patient's configuration. The shell cuirass has a small covered, and so the people with the least metabolic needs and with the least activity, such as muscular dystrophics, goes from the second rib to the umbilicus, and only the diaphragms move. There's no chest wall motion. You can see from the connections here. You can see how the chest wall is free, the chest wall is partial, none, and then the torso, which is the exovent, which has it's a big box and has similar to the tank respirator. So that's what's available. Here's the fiberglass. The advantage of the fiberglass was created by a patient is it weighs 100 pounds and it's completely mobile. So Sonny would go camping in his fiberglass. This is the poncho, and unfortunately, the problem with the poncho is it has a million little clips, and it was very difficult. It takes 20 minutes to more than half an hour to seal, and then you had all kinds of leaks. So the grid system works very well, and it's, again, for children, it's much easier. Compliance was poor, and then some of the studies in the literature, that's what they use. Compliance was so poor, it didn't help. Well, you don't use it, it's not going to help. I actually created this, if you will, suit, a pneumo suit, which I call the pneumo suit, which is made of Gore-Tex, and it's got a scuba zipper, so it's completely sealed, with closures of Velcro at the neck, the wrist, and the ankle, and that with a grid. And here is a COPD patient who had a PaCO2 of 80 in core pulmonale, and she is at home with her nebulizer, which she uses every night for sleeping. There's her oxygen. And during the daytime, she was out unless she was playing in the church. Playing an organ is quite physically demanding, but she would then go back into the suit for an hour before she had lunch after church. So that works extremely well. It's very comfortable, completely washable. It's Gore-Tex. But these are more modern cuirasses, and this is the Hayek biphasic, which has acylation, which is supposed to help move secretions. And here's one of our recent patients. He's 19-year-old. His face is completely molded he's been on facial ventilation since age 3 weeks. He has severe scoliosis. And this is the Hayek, which he uses for sleep at night. This is Jamie, who had a extremely rare condition, which resulted in probably 3 to 4 surgeries a year up through his teens, because he had multiple lymphangiomas, hemangiomas, and he had functioning one lobe, the left lower lobe, which had bronchiectasis because he had a trach from the time he was a child, and he had multiple infections every year. We transitioned him to a customized cuirass. The only pump available was that, so we tried to mute it with carpets. But since that time, he did so well, he moved to California, where he works now, without a trach. And when he was in the hospital 3 or 4 times a year, he hasn't been in the hospital since for the last 12 years. But this, I'm not going to do this. This is, if we have time for it, these are videos of Jamie. Maybe I'll just start it and you can see.
I was born with lymphangiomas and hemangiomas in my arm and chest. And like she said, my first surgery was 6 weeks old. And then I pretty much had 2 surgeries a year until I was around like 13. And then we just took a break, mainly because a lot wasn't getting better and I was just tired of having surgeries. And then as I progressed, as I got older, we just noticed that there was severe scoliosis developing. But when I was around 18,
I'm going to move it further, not because I don't want to. I just want him to.
Cycles to see how.
I want you to just take a look at what he's using. See how he's using his shoulder to breathe? Quiet breathing. He's using his shoulder.
Well, multiple surgical incisions, obviously. And so that there is no easy way to measure his rib cage excursion. You can put your hands here, but there's really no motion. In fact, if you put your hand here, the right rib cage moves out, but the left moves in. So we have paradoxical when he's off. When he's on negative pressure, everything moves synchronously in the appropriate direction. Now, if you feel his abdominal muscles,
So,
out how your day goes. What's your normal day?
Stop it.
Muscles. How's the next comment?
So I'm going to skip this one because
right. I was born with lymphangiomas and hemangiomas in my arm and chest.
And we'll skip this only because he was now living at home, doing very well. He's a graphic designer. He works on his computer. If he gets a cold, he still works at home.
Day goes.
Oops.
What's your normal day? What do you do?
Okay. So this is the exovent, which is fairly cumbersome. It can have the head elevated. You can do it supine and you can do it prone. And this is kind of how that works. It's continuous negative external pressure, and the negative pressure with 5 centimeters over at the end in order to prevent small airway closure. But because of where it fits, you have good chest wall and diaphragmatic excursions. Now, this is what happens with the tidal volume in healthy paralyzed subjects. They're willing to be temporarily paralyzed, and recovering polio subjects. And this is a normal spontaneous breathing. Whoops. Anyway, it doesn't matter. You can see that different people have different levels of ability to expand, and each of these is tidal volume by different subjects. The red is the iron lung, but they're all different. The green is, the red is the exovent, the green is the iron lung, and then the blue are the cuirasses. So the cuirasses with the least potential expansion of more dimensions has the lowest tidal volume of those cuirasses at that time. But to me, the most important thing is looking at what you have here is an increase in FRC. And with it, you have a tidal volume here is generated with different pressures, but the reduction of atelectasis. So you can see that the control breathing and tidal breath when the negative pressure is on, and just turn it off, the normal person immediately changes the frequency, which is a response to that. But this is the change of the degree of atelectasis between positive pressure and negative pressure. So during normal expiration, normal subjects, here is a negative pressure. Atelectasis is reduced from positive pressure because the distribution of transthoracic pressure change is greater in negative pressure since it mobilizes the diaphragm and the chest wall. Here is 3D printed. This happens to be a normal subject with a venti. I'll show you one for a patient, but this one is attached to a neoprene shirt that you put on through your arms and zippered in the back, and it's a very good seal. And for people with negative pressure requirements in less 20 centimeters or less, the motor is within the shell, so they're completely portable. And therefore, the chest deformity, patients with deformities can be fitted. Now, here's one of our patients in who he is post-polio. He is severely kyphotic. These people have no extra fat. He's scoliotic, and he has had terrible time trying to get it fit. And every time he used a BiPAP, he got otitis media. So it was impossible for him to use it. This is how it's strapped on. It goes across the shoulder, supports the back, and the front, which holds it in place. And here, this is the same patient with that you saw, and here he is with the customizable vent. So he is now, he was used, we have FDA approval for compassionate use so far until we get larger studies going. So the Dima Italia pump is lovely. It's 10 pounds, has a lot of all the features we like when we're in the ICU. So it's easy to apply. The ventilation modes are quite acceptable, and you can do high frequency for secretions clearance as well. And you have assist control, and there are 2 models for pump power. And there are 9 different sizes of chest cuirasses for patients. But what are the indications, for switching from positive to negative? And then what are the contraindications, negative pressure ventilation? So obviously, patients with facial decubiti, which we see with a lot with facial ventilation, mask intolerance, inability to fit, especially with altered facial anatomy from facial use in childhood. Hypercapnia encephalopathy, uncompensated respiratory acidosis are not good time to start the non-invasive system. Non-invasive systems in patients with severe sleep apnea, especially when they are very overweight. Though sleep apnea patients using negative pressure can have a minimum CPAP to overcome that. Severe obesity, the apple, definitely no. The pear, it depends on the patient's configuration. Severe kyphoscoliosis, except for the custom venti, and of course, if you have acute rib fractures. A recent abdominal surgery, because it may be painful. There's an auto suppression of diaphragmatic activity after cholecystectomy, so which I find very interesting. If it hurts, the brain says don't move it. And obviously, patients with claustrophobia. Very few patients on the exovent so far, because there's only been a very few trials so far, have experienced claustrophobia, but it is more mining. So we're going to talk a little bit about reverse ventilation, just because it's a whole different non-invasive system, but it was started way back 1933, when he was a chemist and physicist whose friend had trouble breathing. He probably had muscular dystrophy by description. So he created an inflatable belt wrapped over the lower thorax and abdomen, inflated it, forcing the air out, elevating the diaphragms. And then when it deflated, the diaphragms fell down. And this was used for supporting polio and diphtheritic patients with diphtheria who developed diaphragm paralysis, a diaphragmatic neuropathy from diphtheria. And it's been used for over 50 years. It's still being used now because it allows school, Jody, the guy I showed you, is now in college, work, social life, and reduce hospitalization quality of life. Well, we'll skip the rest of the stuff because of ARDS, especially after the Vietnam War, and Asbaugh and Petty's article describing ARDS began the explosion of positive pressure ventilation and development of many, many positive pressure ventilators that are current in use. As a result of disuse of these other systems and development of the ICUs, because with polio, we developed respiratory care units, but it was not the intensive ICUs that we see now. But the disuse of negative pressure ventilators and less need for pneumo belts. And of course, that meant we didn't train anybody to use them. And then of these, nobody developed confidence in using these systems. But here it is, the system with the belt. So this is a sitting, so here's the bladder that's inflated. It pushes the diaphragm up and air flows out. And then when the bladder deflates, everything falls down, the chest wall moves in, air flows in. It's quite analogous to normal breathing. It's quite comfortable too. But here's the difference in muscular patients in tidal volume achieve. The blue and red are the spontaneous single breath, and the green and navy blue are the increases in tidal volume from use of the belt. And here is a change in peak flow. How important is the peak flow? Well, that's because you can't get secretions out without good peak flow to scrub the airways. So each of these subjects had different, they're all also different size people, but you can see that peak expiratory flow increases is helpful to clear secretions. Now here is the old belt, the old corset-like thing. It was a Duchenne patient using it in the 70s. And here is Jody, the prune belly syndrome, using this, which can be under the clothing. He's going to school. And the other thing we're trying to do is improve his nutritional status because he's been offered an opportunity to correct his, at least reduce the severity of his scoliosis, which is over 120 degrees. And here is a young man with muscular dystrophy. You can't even see the belt, it's on, but he's now traveling by airplane because the pump on its own battery is in his chair and he's ready to go. I'm not, maybe just a few words of Donna. Yeah. She's used it for 20 years. She used it with a peg in place. I'm going to stop this because it's going to take too long. But it just tells you that she was happy to share this experience. And none of these patients, by the way, wanted their faces hidden. They said, no, 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 you can show me. And they gave me consent, which was marvelous. But at any rate, very comfortable, dressed. She works on the computer, and she goes to work every day. So long-term patients, the one paper was 54 patients with used for average of many, many years. They had unmeasurable forced vital capacities. But some of them could do glossopharyngeal breathing, which is swallowing air into the lungs, and they could stack. And one of my post-polio patients had a vital capacity of 170 ml, and she was able to stack to 1.2 liters, so she could talk when she was off her ventilator, but she still used the belt because they can't keep it up. Those muscles of swallowing used for breathing were not designed for that purpose. Anyway, you can see that these patients had daytime use for 640 patient years, and the failures were the severe scoliotics because we didn't have the customizable cuirasses at that time. the morbid obesity because it takes too long to move the fat, and the fat has already moved the diaphragms up. The chest wall has already moved in to reduce the chest capacity. So it's very hard to change that. So BMIs over 35 with comorbidities over 40 are poor candidates. New belts have many sizes, which will be fittable for each patient. And the trilogies, which are no longer used for positive pressure ventilation, are excellent pumps for this purpose. And the DMEs can charge for the ventilator, and you don't have the respiratory risks because it's just pumping into a rubber bladder. There are LTVs, or old positive pressure ventilator systems, can be used, and the Breers is a relatively new one. And we haven't tried the Vosen yet. I love the Vosen, but it's not yet been tried. So what are the differences between a positive pressure ventilation and negative pressure ventilation? Basically, we have nasal masks. They have to be closed, tight fitting pressure, and they have sores and mold. Negative pressure, no. Lung infection risks are much higher in positive pressure systems and low in negative pressure systems. Oral infection, dry mouth, higher in positive pressure system where you're using it without a trach. Low in negative pressure systems, very low. The pneumothorax risk is more common in positive pressure systems, extremely rare in negative pressure systems. Sedation often required in the acute state, and chronic you don't need it, but yes, it has its own deleterious effect. I feel very strongly that sedation loses the most important computer, the patient's own brain, for dictating how he integrates his system for his or her needs. And that's not ever required in negative pressure. Intubation, obviously, with airway trauma, loss of speech and eating, and not with negative pressure. Duration is preferably as short as the patient needs, and chronic is based on the individual and the type of system used. And negative pressure has been used for a lifetime. I have several patients used it for over 50 years, and they lived and worked and married and had families and all the rest. The other effects in a positive pressure ventilation system, the cardiac output is reduced. Negative pressure, it's increased because venous return is increased. As you can see, with increased venous return, you have better VQ. But when the distribution of ventilation is to the upper lung zones where there's less perfusion, unless you're supine or prone, the VQ is worse. In positive pressure ventilation systems, the recruitment or diaphragm use is little, which may lead to further disuse. And negative pressure ventilation, if they're closer to normal in terms of motion, but if the diaphragm's already abnormal, they may be spared the rapid continued deterioration by having a support system for part of the time. Pneumothorax risk already mentioned. Lung recruitment, upper lobe expansion in positive pressure systems, more atelectasis in the lower lung regions, which is like almost routine. And the negative pressure systems, either the cuirass or the pneumobelt, though that's not negative pressure, has much more lower lobe recruitment with reduction in atelectasis. GI function, face mass, more aerophagia. There's less GI motility with positive pressure systems. And with the better motility, especially with the exfoliation belt, the very gentle massaging of the abdomen with each positive pressure, it actually reduces constipation in many of the neuromuscular patients. Anyway, thanks for the introduction, interruption, and comment. And negative pressure system can be used for many, many years. And in fact, it can be used for diagnostic procedures that the patient needs it. Because they have a negative pressure system, you can actually do endoscopy, colonoscopy, and things of that type. Anyway, published data, it's been very mixed results because part of it's almost impossible to do a controlled randomized study. But it started back in 1965, and then in Spangard showed it over 20 years. He used it in neuromuscular patients, COPD patients, fibrothorax, scoliosis. And they found that it did unload and support the diaphragm inspiratory muscles. And most importantly, it was able to reduce CO2 to normal levels, improving the quality of life, reducing hospital days and costs. And then the different acceptances depending upon what the variable outcomes. So who, when, and how? Patient selection, acute versus chronic, depends on the rate of change for the acute. Could it be in the ED? Yes, it could be in the ED, depending upon the patient. When to start hospital, it can even be done in the home. And I'm doing patients in the clinic now. And with the modern technology, I'm doing FaceTime in the home to set patients up, working with the respiratory therapist and the equipment and the patient, and more important, in their environment and with their families. So how do we select system? Available equipment, trained caregiver team, patient characteristics. Unfortunately, we always are stuck with the insurance system, and the DME who can serve the patient. I always describe the systems, let the patient understand what it is. I have other patients who've lived with systems, talk to patients about what their experiences are, and we establish goals of care, whatever it might be, including palliative care and end of life decision making. Maybe not the day one, but certainly as part of the program of how life goes forward from that point. So we are then integrating for developing respiratory society, because how do you set these things when the patient can't tell you it's right or wrong when they're intubated? They can't. They either quote fight the machine, or the graphic screens don't show you this dysynchrony, or patients struggling, what have you. So that's why we sedate them. But the central nervous system integrates the entire system: the metabolic demands, the red cell mass, the acid base, the compliance, the resistance, the postures, the activity levels, whatever the dimension of the individual, and swallowing. Patients want to be able to eat and swallow. But we won't talk about parturition elimination at the moment, but even sexual intimacy is important to patients, of how they can accomplish that in some of these more non-invasive systems. When the patient's brain is satisfied with the settings you created or set for them, there's no shortness of breath. When drive exceeds the response, there's no match. They're dyspneic in the system. They're tachypneic in the system. They're struggling with the system that needs to be changed. Doesn't matter what the numbers are. It's matching is the most important thing we can do. And it is extremely satisfying to the patient. That's why I talk about satiety. Are there complications? I mentioned some of them earlier, so we can forget about the iron lung at this point because it's no longer available. But cuirasses that are stuck to the chest wall can abrasions and pain on contact points. If there are leaks, they may be less effective because the pressure is lost, but they may feel cold, and especially in spinal cord injured. So I've handled that because they have trouble maintaining body temperature. I use a small heater. Aerophagia, gastric distension, and nausea, vomiting occurs very, very seldom. With patients with bulbar palsy as an ALS, they're the highest aspiration risk when this may not be the best option. Upper airway obstruction, especially when you're obese, or the upper airway and anatomical problems, when you need higher transthoracic pressures when asleep, that's when you can develop upper airway obstruction. Now, we talked about that, so I'm going to skip that for the moment. So what are the outcomes of using these systems for a long time? Improving gas exchange hemodynamics, reducing atelectasis, less need for oxygen supplementation. Diaphragm gets a rest, if you will, but at the same time as lowering CO2. That improves cellular function. Quality of sleep is very important. It reduces daytime fatigue, improves cognitive function. And when you can talk, you're connected. And when you can eat, you're better nourished. reduce rates of decline of primary disease. That's why people are living so much longer. Kids with neuromuscular disorders who died in infancy or early childhood and are now living to adulthood. Even CF patients. Rare to no rehospitalization, perhaps except for diagnostic test or treatment of a new disease. And this does reduce healthcare costs. Also, when they're working, they're paying taxes. So relying more on normal breathing, people's social life is improved. And long-term results have been very favorable for many, many years. And again, effective for more slowly progressive diseases in maintaining stability and equilibrium. Lower metabolic demands on respiratory muscles. I actually did a study on patients, and I discovered that patients with severe respiratory disorders may be using 40% of their totally oxygen consumption for just breathing. They're just sitting quiet, lying down. They may be, instead of the 8 or 10% that normal people use of their total energy demands, oxygen needs. And again, reducing hospitalizations and reducing death rate. What are the possible opportunities now for us to consider? It's already being used as a bridge to cardiac transplantation because waiting for an organ, patients are dying more than organs are being retrieved. And the successes in children, because they're easier to ventilate with the HIAC system so far, and they're increasing reports in literature, but they tend to be a few cases here, a few cases there. Currently, patients with traumatic brain injury in Texas are being placed on negative pressure systems. They're having continuous intracranial pressure monitoring because positive pressure positive pressure ventilation increases intracranial pressure and reduces brain injury recovery. So we're trying to look at that just beginning. What are future uses? Well, I can see where we can wean patients positive pressure ventilation sooner, extubation, and put them in the HIAC, the Venti, or the Exovent, or even the pneumo belt. Can you use preoperatively to improve the status of high-risk patients to allow after surgery, safer surgery, and reduce post-op complications? And we want to start a protocol, which we can do here at Mount Sinai, a bridge to lung transplantations, because using negative pressure instead of more and more supportive by trach with all the complications that go with it, especially infection for transplant patients, to reduce the risk of death, waiting for lungs, because the wait for lungs is even longer than for hearts and other organs. So this is the protocol we want to start here. And is there an adjunct to rehabilitation for many? Because if you can't breathe for what you're doing at rest, how are you going to do rehabilitate? So by doing that, I actually did that before portable systems were available, just with a long extension cord, to allow patients to be able to rehab and go home. And whether rehab institutions can be set up to do this kind of thing to facilitate rehabilitation. Nobody wants a ventilator, but clearly if they have something that extends their capacity to function when they're not in the system, it is preferred by most patients. I've had very, very few patients actually refused. And the careful patient support, oh dear, I don't know what, anyway, we'll end it there because I said there's an unstable connection. I don't know why all of a sudden, but anyway, that's enough of that. So there's enough time for some questions.
You sound okay, Norma, so I think the connection is okay.
Okay. Well, anyway, we'll, there's a bunch of references I can give you, but I didn't decide to list them all here. Anyway, thank you very much. Hope you have lots of questions. I hope I've triggered your curiosity and desire to try these systems. One thing about it, it helps a lot. Anyway, I just checked the chat and it's the it's a number to get your CME credit for any questions at all. Any challenges, I welcome.
So you are a legend, Dr. Brown, and you are our link to the time when these ancient diseases like polio were commonplace. And, you know, when I trained in India, there was still quite a bit of polio, though, you know, India and most of the world is now polio free. But there are other ravages that find use of non-invasive ventilation, and I find it really interesting and intriguing. And it makes kind of intuitive sense that people waiting for, let's say, lung transplantation or those that are very deconditioned could use this for rehabilitation. That's fascinating. Tell us a little bit more about, for instance, its use for a pre-transplant optimization.
Sure. I mean, patients waiting for lungs are often maximally medically treated. That's why there's nothing else left except for a transplant. And because of that, they have a lot of tissue excess water. And when they're transplanted with a normal lung, the connections, they connect vessels, they don't connect lymphatics, they don't connect nerves, they connect obviously airways. But that a normal lung with normal tissue is not edematous, whereas the recipient lung is. And there's a risk there, therefore, where the recipient's tissues with a rotten lung removed is still edematous, and there is increasing chance for leakage, both airway and vascular, which means another surgery. And increased risk for infection if they have problems because they have prolonged intubation after transplantation. So if they're out of shape, to add to the risk of the increased work after transplantation, with all the metabolic changes that take place, not even talk about the medical one, you can, with negative pressure, you can actually support the function, reducing the work and reduce the edema of the host so that there'll be less leak and less potential for reoperation. And perhaps because now they're accustomed to the negative pressure, they can be extubated sooner so they have less of the positive pressure negative consequences on the transplant itself. So that's the hypothesis for why we want to try to do this. And so we're just going through, the FDA is very slow in getting it done. And it's very hard to do randomized controlled trial. You can't ask a patient with lung transplant to go with the old system and use this and compare because they're not comparable. So the patient is the only control, his own control for this kind of study. So it's not an easy one to do, but I think that if we start with 5 or 6 patients and we can show the difference compared to historical controls, that it can make a real impact for patients. Same thing with rehab. If they can sleep better at night, we know, and I show you the data on that too, is that when you put patients in these non-invasive systems, they have more REM sleep. And with better REM sleep and with now normal gas exchange, their daytime function is so much better. So physiologically, they're improved. Their muscles got to rest for a short period of time, and now they can do the work for the rehab. So if they get support, and then even during rehab, in patients who are, for example, have been in the hospital for acute problem, and you want to get them to rehab because we all want to reduce the length of stay, but we can put them on the system and allow them to start rehab sooner, supported. And then as they start to improve, you can start reducing the non-invasive system accordingly. But then they have an option if they get an infection, if something else happens, they can then go back to a system they know, are familiar with, are comfortable with, and then get a respite. Maybe not even have to be re-hospitalized. I mean, that's what's happened to Jamie. He has not been rehab. He was in the hospital 3 or 4 times every single year after they stopped the surgeries. But then that is totally stopped. And he loves not having a trach. He just loves not having a trach. The secretions has diminished dramatically, though his bronchiectasis, unfortunately, gotten from all those pneumonias, remains, but has not gotten worse. That's the whole point. You know, he's not like a typical bronchiectasis patient that we're familiar with.
Yeah, I was looking at what you were talking about, and in fact, there is some work people are doing. When you evaluate the donor lung, you do this normothermic ex vivo lung perfusion,
Yep.
and they found that positive pressure ventilation, even to evaluate the donor lung,
Yes.
harms the lung a little bit. And they're looking at negative pressure ventilation to decrease inflammation and lung edema in the donor lung during normothermic ex vivo lung perfusion.
Yep.
Fascinating. Please, I don't want to, monopolize your time. Please feel free to ask questions. This is a rare opportunity to look at a very uncommon practice.
All right. Well, I mean, some of the studies I did, I was able to quote recruit normal subjects. And I did some of my RQ measurements in normal subjects too, under different circumstances. But at any rate, the interesting thing is that, well, fellows, physical therapists, respiratory therapists, other pulmonary attendings are the ones I quote recruited. And they found it very interesting feeling. They were surprised, in fact, how comfortable they were, and fell asleep in the lab under those circumstances. So I think that, well, I use what I call a lot of verbal anesthesia. I talk to the patients, explain what's going on, explain a little bit what they're feeling, and tell me when it doesn't feel right. So I keep it fairly simple, and then I talk them through this thing. I use verbal anesthesia for a lot of things, including during bronchoscopy. One of the physicians I bronchoscoped, I use almost no topical anesthesia because I let him look at the teaching scope, and he said, I never thought I could see myself running down a tunnel. So, so when you're focused like that, you don't really need as much anesthetic, which I find the brain is an incredible tool. I like to use it a lot because it to me more reliable than anything else I can guess at and estimate at or measure. Because anytime you measure, by the time you get the answer, it's after the fact. So we're always chasing patients, I think, with data because we get them at a point and the results at a point when it's after the event already. You see this obviously much more in the unit because things are moving much more quickly in the ICUs.
Got it. Folks, the question hour is open.
Challenges are welcome. And get in it, get into a system, see what it feels like. That's why I tell all the fellows to get their own PFTs done. They've got they're respiratory gymnastics.
You have a system at Morningside?
Yeah, I'm putting patients in systems right now. Yeah. So.
All right, if there are no questions.
You can send me email questions too.
Yeah, you can email questions to Dr. Norma Brown at the usual email address, mountsinai.org. So thank you so much, ever so much. This is very, very interesting and actually a lot of fun. And who knows, we may be visited by polio, God forbid.
I know, not with RFK as the non-medical expert heading Health and Human Services. It's so frightening. We must stand up. And I find very interesting that the Trump administration has not targeted Mount Sinai despite our diversity, equity, and inclusion programs. Isn't that interesting?
I have no comment, Dr.
I understand.
Thank you once again. We'll see everyone again at in 4 minutes in the critical care committee meeting.
You bet.
Have a good
Take care. Thank you.
Thank you.
Pleasure.